Well, yeah. Good evening, everyone. Once again, I got the opportunity to share some exciting cases actually, and in the emergency room. It's not I actually suggested to do the talk in the emergency room on critical care unit. Normally in the UK, critical care is done by the anesthetic and critical care physician. But the emergency room, when somebody have got cardiac problems, then we are called or the A&E registrar or A&E consultant. They look after the patient. When patients, I'll show some interesting cases actually that give us a very challenging time, as well as that help us to gain our knowledge. Emergency room, normally when you get called because of somebody about chest pain, or somebody having palpitation, or somebody have shortness of breath. When the A&E team cannot get the clue, and then the cardiologist step in and they try to solve this problem for the better manage of the patient. Probably you don't see, I'm not quite sure about here in Bangladesh, you don't see VA scan. Have you started VA scan in Bangladesh? But normally in the UK, and at least I can tell you that all the London hospitals, most of the countries you see, we actually handhold echo. This is we call VA scan. When we talk to the patient, taking history and our initial examination, then VA scan is so useful to go to diagnose problem. So I'm presenting some interesting cases. One, a 52 years old, a lady presented in the A&E with chest pain and palpitation. And on this patient, an ECG suggested that there were some ischemic changes. Also, the reason people in the A&E was very, very confused, but it looked like a funny picture. What is that? An X-ray is it's not like a normal heart looking. And then also that patient, troponin was raised. So we got ischemic changes, positive things for ischemia, and also raised troponin. And there was an X-ray. So what is next? Until you're taking this patient to cath lab, what you need to do, we need to quickly scan this patient with the VA scan, the handle echo I've shown you just now. So this is first one, echo. Look at this one. Can you please someone help me by echo is actually in the I can move to next one. Can you move to next one, please? Okay, it's working now. If you look at this echo on that patient with chest pain and palpitation, you can see the valves look normal, but the LV look a bit dilated. And now moving to next one, after doing the past and then long axis view, now the 4-chamber view, that again we didn't get any. So what's happening with this patient with 4-chamber view? Can someone please help me? Just I don't know why. Okay. Okay. Can you please stay here? So, if you look at the 4-chamber view, and also on the 4-chamber view, if you look at the valve, there is no problem, but still patient having chest pain. We didn't get any clue what's going wrong with this patient. Then this patient, the next step, we took this patient to the cath lab. Well, this is the gold standard for any patient if you cannot get to any clue. Then if you look at the angiogram, look at the first one, this angiogram is normal. Now look at this one, this angiogram as well, this is normal as well. Now, we didn't get any abnormality in angiogram. So still patient is complaining of palpitation and patient is saying loss of chest pain. No changes there. So that actually confused us even more. So one of the common or standard practice when on the VS scan, if we get some problem, we need to do the proper comprehensive echo study. So on this patient, perfectly normal, people having chest pain and people having palpitation, then what we have arranged, we wanted to see is there any kind of obstruction or any other changes. So then what we did here, we did contrast echo. If you look at the contrast echo, I'm not quite sure how much contrast echo is done in this part of the world. And contrast echo, what we have seen, the apex is dropping out of the apex. And this is look at another contrast echo on this one. What we also see, the apex we cannot see properly. So what might think you might be having this problem? We are not quite sure about that. What is the underlying problem with this patient? It gave terrible time to all the cardiologists and everyone in the department. This is something in a very, very interesting case. This is one kind of cardiomyopathy. I think this is going more interest in recent years is Takasubu Cardiomyopathy. That is, another name is stress cardiomyopathy. This another name is broken heart syndrome. And if you look at this one, and especially anybody when we do echo, normally if you look at the echo, apex is look like conical shape. If you look at the middle one, on this one or the middle one, apex is not kind of apical or conical shape. Its apex look like bigger. When somebody developed this, what's that called, Takasubu syndrome or stress cardiomyopathy, when we echo any patient, without echo, we cannot diagnose any patient of Takasubu cardiomyopathy. There is a very characteristic changes happens during stress cardiomyopathy. The base, when you look at the base of the heart, it is hyperkinetic. We miss those findings. Hyperkinetic. Apex is hypokinetic or akinetic. This is very interesting because it's a hormone underlying pathology. Most of the cases, it is hormone is the cause for that. Is catecholamine releases. So during the time the hormone releases, and you got to see hyperactive, hyperkinetic base of the heart and hypokinetic apex of the heart. And this, because the hormone, when a hormonal surge happen, and that's what you can see. So you might ask, so what are the diagnostic criteria of somebody having a chest pain and having palpitation? You got angiographically normal coronary arteries, then you got elevated troponin and reduced ejection fraction. So one of the things you get to know, because heart cannot feel properly, and eventually it results in low ejection fraction. So whenever we scan any patient, we need to be very mindful about that. Are we looking at the base of the heart with echo while doing echo? Now, look at this slide, and I think probably many of you can remember the 2006 when Germany World Cup, hosting the World Cup in 2006. During the sports, few supporters actually died in June and July month. And in our area, postmortem is not kind of a standard we always do on a patient, but in the West, postcard autopsy is a common thing. Is if we do not find the cause for that, on that World Cup, lot of German supporters actually died because of Takasubu cardiomyopathy. So if we look at the recent literature from 2010, it would be 2017 apology, it will be number of publications on Takasubu Cardiomyopathy from year 2010 to 2017 is increasing. So you might think about what is the underlying mechanism, what's causing this kind of abnormal pathology. So first, it is not fully understood yet. We don't know anything about Takasubu cardiomyopathies. We are just trying to rule out or different kind of hypotheses we are thinking about that. And this is, I mentioned already, this is hormonal, catecholamine release from the brain. And what is happening, catecholamine release, and if we do blood test on catecholamine release during that symptomatic time, catecholamine level will be raised and starting, and histologically, and this is catecholamine cardiotoxicity, and the pathologies they can compare when somebody have catecholamine cardiotoxicity, their slide is almost same like Takasubu cardiomyopathy. Then, as I mentioned, that's already showed, angiographically it was normal coronary arteries. That again, the challenge, is it a microvascular impairment? And obviously, certainly there was some presence of microvascular abnormalities, or we are coming to conclusion, is the microvascular problem, is the trigger for Takasubu myocarditis? And another hypothesis is coronary spasm. What is very interesting, this kind of chest pain is not artery is the trigger. There is no coronary arteries has got any block. It's just hormone is causing this problem. Hormone is causing coronary arteries to spasm or squeeze. But angiographically, most of the patients with Takasubu cardiomyopathy, angiographically, they are normal. So what happened then, and when this sequence events, and you see, I mentioned already that base of the heart, because of the hormonal different receptor, they actually constrict heart on the base of the heart, and base of the heart get constricted, but apex of the heart become a balloon shaped. Sometimes, you might find, some of you might have seen that why it doesn't see you all the time. It comes on and off when the hormone releases. So, and left ventricular function, and it is a study done by on 30 Takasubu cardiomyopathy patients, compared with 20 patients with age-matched control. And that's classic echocardiographic parameters, longitudinal strain and LV twist parameters were assessed and compared between their group. And result is not very satisfactory. And this, I mentioned that probably if you watch or listen to Western music, Don Williams is one of my favorite singers. He has a great song, Broken Heart Never Mends. So this Takasubu syndrome is a broken heart syndrome. Normally, when you get to see this broken heart syndrome, when somebody is emotionally unstable, it could be somebody passed in the family or close relative or friends, or watching football match, died suddenly, or chest pain, all within sudden cardiac arrest. It's like, this is one of my favorite songs. Whenever I listen to this song, Don, some broken heart never mends. And that study shows, and we don't know about this broken heart syndrome. Whether we could fix it, we cannot fix it by angiographically. So what is the treatment then? Some broken heart syndrome, they can present as, like when they are in shock, we need to give actually intra-aortic balloon pumps to support blood pressure. And sometimes we get long QT syndrome, and during that time we need to give IV magnesium. So you might think about that. What about that palpitation? Can we give beta blocker? Please don't do beta blocker. If you have to treat this palpitation, you need to combine alpha blocker and beta blocker. So that was my first case. This was actually quite challenging case. Until and unless you get experience one Takasubu cardiomyopathy, you're never going to think how difficult could be your job in the emergency room. Now, next, move to second one. That's a 52-year-old gentleman presented with chest pain, and on examination, and blood pressure was unstable, not honest, 160 over 70 millimeter of mercury, and early diastolic murmur. So, and that was the ECG. On ECG, you can clearly see that in late 2, 3, and AVF is clearly you can see inferior wall MI. When somebody see in the inferior wall MI, then you start contacting the cath lab teams. We have got someone got inferior wall MI. Please get ready. We need to put a stent in. So all the inferior wall MI, we shouldn't think about, we can fix this problem with the stenting. So on this patient, can you please help me? This is on that patient, paralyzed under long axis view. What you can see, aortic is dilated, and also diastolic flap. Also is 5-chamber view. Can you move to the next one? Okay, go on. This is short axis view. Also, again, you can see the section flap. And this is when I put color flow, and that you can clearly see this is aortic regard, this is eccentric jet. So, and now what we have got in the emergency room, that patient presented with chest pain and shortness of breath. It is quite interesting case. In aortic dissection, more than 90% of aortic dissection flap may extend into the right coronary artery and may present in the inferior wall MI. So all inferior wall MI, we don't fix with doing stenting in. What we need to do with this patient. So whenever we get this patient, did you think about asking about one very important question? Did the patient radiate towards back? Second question, did you listen to the new onset aortic regurgitation murmur? And did you rule out infective endocarditis involving the aortic valve? Sometimes infective endocarditis, they present like almost similar like that. So I'm not going to show many cases. So my final message for this one. So what would be take-home message? When we do echo, whatever the emergency room in the cardiology, look at the aortic root for dilatation and dissection. To rule out is not a dissection presenting with inferior wall MI. Second thing, did you rule out Takasubu Cardiomyopathy, a postmenopausal women, especially 55 years plus, presenting with chest pain with normal coronary arteries? Around 90% of Takasubu Cardiomyopathy are postmenopausal women. We don't still know what's the underlying mechanism for that. And any time, if we see, are you thinking about arranging a contrast echo for kind of, I mentioned that I have a couple of interesting cases in thrombus. So, and I have seen just one that presented before me. She showed some interesting cases, pseudoaneurysm. So all this pseudoaneurysm or thrombus, with contrast, we actually get to know into clue and get a better result. So, and that's my presentation. And thank you very much for your patient hearing. And any question, I'll be happy to